welcome back to another episode of the Rick and Danny Show. Glad to be here. Danny, how are we feeling today?
Feeling great, Rick. Really excited to be here. It's summertime. Kids are off for summer. How's your family doing?
Good, good. Very warm and humid to be expected. You know, lots of sweating and clothes change all the time. Brenna, don't eye roll me.
You're too obvious, Brenna. Come on.
Come on, Brenna.
Yeah, my daughter's at
Forgot I was on
cheer
camera for a
camp.
second, sorry.
You know, we got basketball going on. We got NBA finals. NHL playoffs just finished up with the Panthers with the win.
That's right. Go Panthers.
And then today we're going to be talking about something new, right, Rick?
Yeah, I wanted to, there's been a lot of publicity lately in the news about rising in incidence of cancer in younger adults, especially colorectal cancer, but also other types of cancer. And I think it's definitely, bearing out in epidemiological studies and other things of something clearly is happening that's causing this. And we see it day to day in our clinics. And I know, Danny, you're very in tune to ASCO, which is the annual meeting of the American Society of, Oncology for medical oncologists, and lots of big research gets published there, usually things that end up being practice changing. And I know you saw some things come out of that meeting that caught your eye that relate to sort of this shift in cancer incidence.
Yeah, thanks, Rick. Yeah, there was a couple trials that came on my feeds, on the news feeds. We get updates all the time from ASCO and American Journal of Clinical Oncology and New England Journal. There's all these updates that we get via email, and a couple things caught my eye. One of them being a study that showed a reduced risk of recurrence in patients with stage 2 and 3 colorectal cancer in those patients who were prescribed a structurized exercise program. So I just want to kind of go over what that trial showed, and to our listeners, how exercise can actually potentially reduce risk of cancer recurrence in a patient population that might translate to some of our patients currently undergoing treatment, and I think potentially practice changing. So this was a study that was done between 2009 and 2023. So it was actually a long trial, international clinical trial of 889 participants, 6 different countries. The most participants enrolling were from Canada and Australia. And the median age was 61 years, and about half of patients were male, half were female. And they studied patients who were undergoing treatment for high-risk stage 2 colorectal cancer or stage 3 colon cancer. And they wanted to see if a structured exercise program led to a reduced risk of colon cancer recurrence in this population. So all participants received standard cancer surveillance and follow-up care after their cancer treatment, but they randomized, half of the group to a structured exercise program that was 445 patients, and the other received health educational materials promoting physical activity and healthy nutrition. So it was, here's some material, we recommend this, but again, they weren't prescribed a structured program. In the patients, or it said patients in both groups improved their physical function and sustained it, but there was a significantly higher amount of patients who improved their physical function in the structured exercise program. And probably because, again, it was prescribed for them. They were told what to do. They were supposed to do these exercises. They weren't just given references to do the exercises in the program. Interestingly, the improvements were maintained over all 3 years, and they increased physical activity and VO2 max and the distance that they can walk at 6 minutes. So all those parameters improved. And their median follow-up in the study, and the reason the study was done so long, I said between 2009 and 2023, median follow-up was about 8 years. 93 patients in the structured exercise program had their cancer recur, compared to 131 in the health education material group. So at 5 years, the disease-free survival, so those patients alive and who did not have any recurrence of cancer, was 80% of patients in the structured exercise program and 74% in the health education materials group. So that translated, that was an absolute improvement in disease-free survival, which is basically, recurrence risk. And it was a relative 28% reduction in risk of recurrence in the patients with the structured exercise program. So overall survival, they also kind of wrote in that overall survival was 90% in the structured exercise program compared to 83% in the health education materials group. So they stated that there was a 37% lower risk of death in those that had a structured exercise program. There were more injuries in the structured exercise program. So that was a little highlight that they gave. More exercise, you're probably going to injure yourself more. So, but overall, it did not lead to obviously a decreased survival. It led to an increased survival in those who participated in the structured exercise program. I interpret this as very positive. I mean, I think, all of us who are practicing are probably wondering, well, what is this structured exercise program? How stringent is it? Can patients actually participate in it, and will they adhere to that program in the real life setting? But if we tell patients, because there's not and this, Rick, there's not a lot of treatments sometimes that we give to patients that we can tell them they have a 20-30% reduction in risk of recurrence. Like even some chemotherapies and oral therapies we give do not lead to that amount of a reduction in risk of recurrence. So definitely I think is worth the conversation, but we also need to make sure it's doable in the real world practice.
Yeah, I think that's my biggest takeaway is obviously I think the chance of harm here is very minimal. I mean, telling people to exercise more and giving them resources and education and structured programs to do it is a great thing. I think my biggest hesitancy would be to extrapolate and tell patients there's going to be this huge reduction in cancer benefit, as shown here. I think if you ask anybody what their pretest probability of an effect size this large would be for such an intervention, my guess would be it would be, for most people, nowhere near this close. So that just kind of, it's tough. It would be tough for me to look people in the face and tell them, there'd be this magnitude of benefit. But I think the other way to look at it is, well, really, what's the downside? If you do this in your patients who are able to exercise, I don't think there's really any. So I think it's, it's certainly something that we need to, do more and encourage more in our patients, even probably more than we do. And then the other piece of it is with these is always, how much of the benefit is the intervention, like the exercise, versus those in that exercise program clearly had more contact with healthcare professionals and other people that, has been shown in several other studies that the more check-ins and nurses calls and times you are interacting with the patient, improves outcomes. So distinguishing that piece of it from the true benefit of the exercise is also going to be challenging. But I think I'm certainly glad this study was run, and the downsides are, like I said, very, very minimal here.
Yeah, very little downside to trying. I think in a small practice, we're in a pretty large community private practice. Certainly we could talk as a group about setting up programs, with either, different physical therapy groups or gyms, or, we can talk about getting programs set up for patients. But in smaller practice settings, I think coordinating, getting these patients into a program that you can actually monitor them and see that they're participating in it would be pretty difficult without a lot of resources in terms of follow-up, calls to say, okay, how's the program going? Do we need to tweak, what we're doing here? It's much easier to just give resources to say, this is what you have to do, than it is to actually do the follow-up accordingly. So.
No, very well said.
But yeah, no, I think I'm going to offer it more to patients. I think now that we kind of reviewed this and went over the data, it's definitely something we should encourage patients to get to the gym more often. You know, if they have means to get a physical trainer or a trainer that can help with the exercises, especially with our older population, to kind of guide them through the exercises, that would be helpful. Um, but I think, yeah, it takes a lot of resources to make this program work for patients.
Yeah, I mean, it'd be nice to see resources directed from away from other things that may have lower utility and placed to something like this would be nice. Now, Danny, how do you relate this study and some of these other non-pharmacological interventions that we've seen, and diet as well, has come up on a bunch of shows in terms of, is it something in our food that's causing these higher incidence of early age colorectal cancer patients? I mean, clearly you would have, at least intuitively, I would think that has to play at least some role. But what are your thoughts on that, or any other data that you're aware of that's come out?
I think the most intriguing thing that people hypothesize is just the number of obese patients that, comparatively to 30, 40 years ago. I don't have the data in front of me, but I think that is a strong risk factor for a lot of the cancers we treat. But it has to be multifactorial. It can't only be obesity as the sole reason people get, colorectal cancer at a young age or any other cancer. I think there are multiple contributing factors. So I think the combination of obesity and what you're, taking in your diet on a day-to-day basis, and a lack of exercise, I think there are people that fall on the obesity spectrum in terms of their BMI, but actually live pretty healthy lifestyles, exercise regularly. So I don't think it's just one parameter. I think we need to encourage routine exercise no matter what your BMI is. I don't think we should be solely reliable on injectable drugs like these GLP agonists to just lose weight and then not incorporate exercise, because I don't think the degree of benefit is going to be there by just the, dietary or pharmacologic interventions. We all know that exercise is good for our health. It's good for our cognitive health, our physical health, everything. Mental health, obviously. So I'm a big believer in it. I know you exercise regularly, Rick.
Try to, as much as I can. Yeah, no, it's definitely, there's again, minimal downside here. So, we really should be focusing on these things as a health system as well, and really emphasizing it. And it's just tough because it does require a lot of resources, and the way things are set up with, cheaper foods being usually the more unhealthy. They're also the tastier ones. It's, the system is set up to fail most people. It's very, very challenging to, eat right, exercise. People are working, most people are working 1-2 jobs. It's just, unfortunately, it has to be a priority, and you have to prioritize it just like you would anything else. But it's
a lot of time. It's a timing issue, right? It's like, when do I have the time to go to the gym or get, I don't want to go outside because it's 95 degrees out. There's a lot of excuses that can be made. I make excuses not to do exercise sometimes too. But, again, we generally feel better when we work out. Our brains are sharper. We are healthier when you incorporate routine exercise into your life. So, and I wanted to highlight this other study, Rick, that we're talking about, diet, exercise, pharmacologic interventions to lose weight. Obviously, It's been all across the mainstream about these GLP-1 agonists and how helpful they've been in patients with obesity and with diabetes to lose weight, control blood sugars. I'm sure you've had a lot of patients who are on these, injectable drugs that really yield good, successful outcomes with weight loss and controlling blood sugar. So there was a study done that ASCO, I think, reported out at their most recent annual conference. And it was an observational study, but it was kind of intriguing. So we talked about this study to looked at a structured exercise program in colorectal cancer patients and how it contributed to a lower risk of recurrence and overall survival. Well, this was an observational study that looked at over 100,000 adults in 43 healthcare systems in the United States. And these patients were obese by BMI criteria and had a diagnosis of diabetes. And they looked at the patients over a 10-year period of time and these patients started a GLP-1 agonist, something like Ozempic, Wegovy, Mounjaro, those kind of drugs. And they were seeing if, in an observational study, if they could see a lower incidence of a variety of obesity-related cancer diagnoses. And what they ended up finding in over 100,000 adults on these GLP-1 receptor agonists is a 7% lower risk of developing an obesity-related cancer and an 8% lower risk of death from any cause. In the patients who received one of these injectable GLP-1 agonists, 2,501 newly diagnosed cases of obesity-related cancer out of the 85,000 patients who were on these injectable drugs. And they looked at the difference between the risk of the obesity-related cancer in men and women. And interestingly, for men, there was not a statistically significant difference between two different types of obesity treatment. So they looked at the GLP-1 agonist and they looked at another DDP4 inhibitor. Do you know what that is? Because I don't know a lot about what that is. And we don't use this much in our practice, but they didn't see much difference between the new Ozempic, Wegovy, Mounjaro drugs and this other inhibitor that's used for obesity management.
Dipeptidyl peptidase 4 inhibitor. So,
do you know the trade name of that drug?
Let me find out.
Just so our listeners know.
Sitagliptin was the generic name.
Sitagliptin. Okay.
Let's see.
I've seen that.
Yeah. Satirex, and let's see what the trade name is. Januvia.
Yeah, Januvia. So we do have some patients with diabetes who are on these medications who we see for, oncologic and hematologic reasons. So we're not going to pretend like we're endocrinologists and know, a lot about those treatments, but
long time ago.
Yeah, right. But they did see in women, interestingly, the GLP-1 agonists, the new injectable drugs, had an 8% lower risk of obesity-related cancer and a 20% lower risk of all causes of death in the population. So interestingly, those new injectable treatments led to lower rates of obesity-related cancers in those with diabetes, as well as lower risks of all causes of death. And I mean, I think that's intuitive that you would expect that patients on those medications who have, 20, 30, 40 pound weight losses have lower risk of all cause mortality, because a lot of their mortality is going to be dependent on their obesity and obesity related, medical issues. But I do think it's interesting about, a proportion of that is a lower rate of cancer development. And we know, a variety of cancers are either partially caused by obesity or maybe the lone cause of diagnosis. So I think these data are intriguing, and I think there's going to be lots of data coming forward about Ozempic, Wegovy, all these new GLP-1 agonists and how they lower cancer incidences in patients with diabetes and without diabetes.
Yeah, no, absolutely. I mean, I think it's not just a hormonal imbalance that happens in a lot of patients who are obese, but it's also just the chronic inflammatory state, obviously bad for cardiovascular disease, other things as well. And then certainly as we've learned over the last decade with the explosion of immunotherapies, clearly our immune system plays some role in keeping cancers at bay that we all probably have at different points in our life. And if you're in a pro-inflammatory state and your immune system is dysregulated, I think intuitively it makes sense that, you know, you are going to be at a higher risk of these malignancies. So
Yeah.
I don't think it's unfortunately all the things no one wants to hear, which is the things that are very easy to say but very hard to do: diet, exercise, you know, things that are, we know through millennia are probably good for us, but unfortunately it's just, for everybody, is an extremely challenging thing to be judicious about.
Yeah, I think what they also said in this study is they're going to continue to follow patients, hopefully over, you know, many more years to come, and kind of see if that risk reduction holds true, or, you know, maybe increases with time too. Because the question is, how long do patients need to stay on these interventions? This particular study was looking at patients with diabetes, but we know a lot of our patients are on these medications who do not have diabetes. So, you know, the question is going to be, how much benefit is there? How long do you have to stay on the intervention for the benefit? And
Yeah, that's
we'll
right.
get that data to come.
I don't think we're going to have that answer anytime in the near future. Well, thank you all for tuning in to another episode. Hopefully you enjoyed this little somewhat cancer related topic, but also more general health related topic.
Thanks, everyone. We'll talk to you soon.